Hi everyone. Today I'll be presenting on branchiootal renal syndrome, also known as BOR. So let's get started. So BOR is a genetic mutation, which we'll get into. What happens is there is some disruption of tissue development during pregnancy, and that tissue is within the neck and the tissue that develops the ears and kidneys. So breaking BOR down, we have branchio, which stands for the branchial arches. We have oto, which are the ears, and then we have renal, which are the kidneys. So BOR is a genetic mutation that interrupts the tissue development within each of those three categories. So just a quick embryology review, specifically pertaining to BOR. So we have the outer ear, specifically the pinna. That is from the mesoderm layer, and that is the first and second branchial arches. Then the middle ear, we have the eustachian tube and tympanic cavity, which is from the endodermal tissue, from the first pharyngeal pouch, and the ossicular chain. Specifically the malleus and incus, those arise from the first and second branchial arches. Then we have the stapes, which is just from the second arch. However, the foot plate and the annular ligament are specifically from the otic capsule. And then in the inner ear, we have the organ of Corti and the cochlear duct, which arise from the otic vessel. So as far as the pinna and the ossicular chain go, keep that in mind since those two are derived from the branchial arches, and we just explained that it starts with a disruption in tissue development in the branchial arches. So BOR is, like I said, a malformation due to gene mutations. So I'll take you through some of the genes that have been expressed through genetic testing as to why BOR happens. So we have the EYA1 gene, which interacts with other proteins to activate and regulate activities of genes involved in embryo development. Specifically, the EYA gene helps in tissue formation, specifically in that second branchial arch, the ears, and the kidney. So we can think if something goes awry with that gene and there's a mutation, we're going to have deficits in those three areas that we talked about. We also have the 6-1 gene, which is responsible for proteins that bind specifically with DNA. This gene interacts with the EYA1 gene, which helps it regulate normal tissue development. So also keep that one in mind. And then we have the 6-5, which has the same properties as the 6-1. However, within the literature, there is some question with regards to whether or not that gene, the 6-5, contributes or not to the presentation of BOR. So BOR is passed down in the autosomal dominant inheritance pattern. So I included a diagram here just in case we all forgot what an autosomal dominant is. So one copy of the gene is sufficient in passing down the syndrome, as you can see here. So 90% of people with BOR are inherited from one of their parents who has the mutation. The remaining 10% are new gene mutations that are still being studied, and that occurs when there is no familial history. The case that I'll be presenting on later will be on a person who has inherited that mutation, since that is the most common. BOR occurs in 1 in every 40,000 live births. And the genes that are most commonly linked with BOR, that is seen most commonly through genetic testing, is the EYA1 gene, which affects about 40% of people with BOR. And then you have the 6-1 gene, which is less common. So about 5% of people with BOR will have that gene mutated. It's also a fun fact, I guess, that kids who are diagnosed with profound hearing loss, about 2% of those kids have BOR syndrome. So that's just something to keep in mind. And the risk factors for BOR, well, there are none because BOR is a syndrome due to a genetic mutation. So now to the good stuff. How do we ID and diagnose BOR? Usually it's based on a set of clinical criteria. So you have to take a look at the birth and medical history of the individual. Then you look at the expression of symptoms. So as we said, you have 90% of people with BOR inherit it from a parent, and you have 10% of people who don't have a family history. So if no family history is present, you have to have 3 or more of a major criteria, or you can have 2 major and 2 minor criteria. We're going to go over those in the next slide. And if you have a family history of BOR, only 1 major criteria needs to be present to be considered of having the syndrome. So aside from the expression of symptoms, birth, and medical history, you also have a physical exam, so physically examining the patient, specifically in the head and neck region. And then you have genetic and lab testing to determine what gene has been mutated. Like every syndrome, it's important to note that every person is different and may express their symptoms in a variety of ways, and the severity of symptoms are going to differ between people. So, to those major and minor criterias. Major criteria for BOR syndrome diagnosis is any second branchial arch abnormality. We have deafness, preauricular pits, renal anomalies, and auricular malformations. So for minor criteria, we have auditory canal anomalies, middle ear problems, inner ear problems, preauricular tags, and we can have facial asymmetry, palate abnormalities. Those are the most common that are seen in BOR. And like I said, not one person is going to present with all. Some might. It's all about, making sure you're differential diagnosing these people. So we're going to go into a couple of the big common characteristics of BOR. So like we said, it's problems with the branchial arches, problems with the ears, and problems with kidneys. So we're going to go into those a little bit more in depth. So specifically, it's the second branchial arch that is affected during this genetic mutation. So things that can be seen are branchial cleft sinus tract or branchial cleft cysts. So this cleft sinus tract appears as a pinpoint opening anterior to the sternocleidomastoid muscle, which we're all pretty familiar with when learning VEMS. So this diagram you can kind of see, in the darker pictures, so A and C figures, it shows you the external auditory canal, and you can see the external branchial fistula. Then in figure B, you can see where the sternocleidomastoid muscle, and then approximately where these cleft sinus tracts and cleft cysts have the potential to develop. So the difference between the cleft and the cyst is obviously a mass underneath the sternocleidomastoid muscle, and then the cleft is kind of just an opening in the skin. Then the hearing loss, obviously what we're most interested in. Hearing loss it's important to note that hearing loss is the most common symptom of BOR syndrome. So more than 90% of people with BOR will have hearing loss. So the hearing loss that can present in BOR are, of course, all types to make things a little complicated. So you can have conductive hearing loss, which can be seen on CT scans if there are structural malformations, as we discussed. There could be. Mixed is the most common presentation. Generally, in the case studies and literature, it was shown that there is some malformation in both or in one or the other, specifically malformations in the cochlea, then if there are palate issues or facial problems, then otitis media obviously can occur and, have chronic ear infections, thus, leading to mixed. Sensory neural hearing loss. So that can be anywhere from temporal bone anomalies, so cochlear hypoplasia, absent or hypoplastic semicircular canals, and it's also been studied that people with BOR can have enlarged vestibular aqueducts. So here's some more information on hearing loss characteristics of people with BOR. There's been different data out there. So I read this one article. So this what I'm presenting on now is a little different from what I just presented on. So this was a literature review which revealed a little bit of contradiction within previous literature on reporting hearing loss. The hearing loss described in every article I read said conductive, mixed, and or sensory neural hearing loss can happen. However, where contradiction comes into play is how severe the hearing loss is and whether or not the hearing loss is progressive, stable, or fluctuates. So, there is a reported higher number of moderate and severe to profound hearing loss due to the amount of abnormalities that can occur in the inner ear. Like I said, hearing loss in this particular article that reviewed multiple literature said that hearing loss could be fluctuating and or progressive. Also, it was noted that higher thresholds were reported in those individuals who were confirmed to have enlarged vestibular aqueducts. So this chart here basically looks at the different articles that were reviewed in Lindau et al. Then it tells you the type of hearing loss that was reported, the degree of hearing loss, the pattern, and then it breaks it down even more into the anatomic changes in the external, middle, and inner ear. So I thought this chart was very interesting because it really gave me a better understanding of the variability of presentation of hearing loss in people diagnosed with BOR. So to throw some pictures in to not bore you all more, we have the otologic abnormalities. So like I said, the preauricular pits, which are most common, and the skin tags. Then we have pinna deformities, so cup ears. The ears can also, toward the top of the pinna, can be rotated or tilted a little bit more forward, so not fully a cup ear, but those two have been seen in patients, as well as stenosis of the ear canal. Now for the third category of what defines BOR are renal malformations. So renal problems occur in about 67% of individuals with BOR. So that can be renal hypoplasia, which is the most frequent symptom, specifically in those patients that we said with the EYA1 and the 6-1 mutations. Then we have renal agenesis, which is when one or more of the kidneys are missing when the baby is born. Then you have renal hydronephrosis, excuse my mispronunciation maybe, and that is when there's swelling of a kidney due to urine buildup. So the kidney is unable to drain the urine into the bladder, so then that causes an obstruction or blockage, and that's not the most comfortable. So like I said, because it only occurs in about 67 of patients with BOR, renal exams are only typically performed for individuals who present with renal complications. So usually if a patient, can be born without the renal malformations and develop it later. And so then it's based on, what they're talking to their primary care physician about. And then if they feel the need to go to have a renal exam, then they'll be able to uncover it. So I wanted to include this part of the medical management team of a person with BOR. So we have the audiologist, of course, for the hearing loss. We have the general pediatrician, physician. We have the ENT, and we have a nephrologist who is specializes in kidneys. But we're going to focus obviously on the audiologist since that's what's most important to us right now. So the audiological treatment and management of people with BOR and hearing loss is that obviously amplification to help enable speech and language development, especially in these kids who are diagnosed with BOR early on. This Morisada et al. Article said that 80% of people with BOR who had hearing loss that they looked at found hearing aids to be highly effective. Then we had another study, Lindau et al., which I mentioned before, mentioned the success rate of cochlear implants, and positive responses were observed post mapping with patients, and it increased their speech recognition. So that's also something to keep in mind, specifically, when we are trying to predict cochlear implant success. If, we have a patient coming in with BOR who has a severe to profound hearing loss and they're not benefiting from hearing aids, then, making the recommendation with CIs. Since there aren't a lot of other medical complications with these patients, except for the renal, the success with cochlear implants has been shown to help, and there is, these patients do experience success. So that's something important to keep in mind. There are also surgical management options, so tympanoplasties and PE tubes for if there's a facial or palate abnormality. So now let's dive into a case study. This is from an article. It's from 1984, so it's a little older, but the problem that I ran into when I was researching case studies and articles was that even though there were some more relevant articles regarding BOR, they didn't necessarily go into depth of audiometric testing. So it mentioned, the type of hearing loss that the patient had and the management and treatment options for that patient. However, it didn't go into depth of what exactly their audiogram looked like, what their speech was. So this was the only article that I found full of data. So I'll go ahead and take you through that right now. So here's a background on our patient. She was about 9 years old. She's a proband female. So proband is a term for a family member who presents with a particular genetic disorder, who's the first within the family to be studied by the medical community. So little girl Doe, was born with the umbilical cord entangled around her neck. She was born with bilateral pneumothoraces, which is when air gets into the space between the lungs and the chest wall. So from that, she was admitted to tertiary care, and then she was discharged after 11 days. When she had her neonatal exam in tertiary care, they noted bilateral preauricular pits, cup-shaped ear, right-sided branchial cleft sinus, and prominent epicantral folds. So in neonatal care, she was treated for the bilateral pneumothoraces. So they did a thoracostomies, I think I'm pronouncing that right, which is when they insert a tube between the lungs and the chest wall. So that's to help treat to get that air out of there since it's not supposed to be there. And then you have the epicantral folds, and that is the skin above the upper eyelid that covers the inner corner of the eye. So where your tear ducts are, that's kind of right above there is the epicantral fold. So at 9 months old, it was reported that she had a diminished response to sound. So audiograms weren't provided for that, but then it was reported by her mom that 3 years post that, she had reoccurrent episodes of acute otitis media. And then at 5 years old, she underwent a bunch of surgical procedures, specifically getting her tonsils taken out. She had bilateral PE tubes inserted, and then an excision of her preauricular sinuses, as well as the right-sided branchial cleft sinus. So a post-op audio was just reported, but the data was not shown for that, and so it showed a persistent conductive hearing loss on the right side. Then at 6 years old, she had exploratory tympanometry, and that is a surgical approach where they go through the canal and they are looking in the middle ear to see, what is going on in there. So they basically make an incision, they lift up the eardrum, and then they can get a view of the ossicles. So from that surgery, it was seen that her malleus and incus were fused together, and then the long process of the incus was absent, as well as the stapes superstructure. So that's pretty cool. Not for her, but it's pretty interesting. So some more history. Once the exploratory tympanometry was done, she had a saccular reconstruction, and they inserted a prosthesis in her ears. Sometime within that same year, this little girl complained of frequent dysuria and cloudy urine. So dysuria is painful and difficulty with urination. So we can think about that in the sense of now her kidneys are starting to develop problems. So at that time, they had a urinalysis, which revealed moderate proteinuria and a UTI. I'm sure we've all experienced a UTI at some point, so we know how painful those are. But moderate proteinuria is when there is a loss of too much protein from the blood through urination. So when a patient is diagnosed with proteinuria, there are different levels of severity. However, once diagnosed with that puts you at high risk for chronic kidney disease and damage. So, as I said, the expression of symptoms, as we were talking about earlier, is only in about 67% of people with BOR, but that doesn't have to express from birth unless they notice that there's a missing kidney or a malformed kidney, which they would probably know early on. Things can develop later. So she's 6 years old, and now things are starting to develop for her. So from this point, she was referred to St. Louis Children's Hospital. So now we're getting to a little bit more of the good stuff. So at St. Louis Children's Hospital, when she was referred, she had a full otologic exam. And she was nearing, end of age 6, approaching up on 7 years old here. So they reported her cup-shaped ear that we mentioned before. They had the anteroverted pinna, which is just that top of the pinna gets rotated a little bit more forward. And she was noted to have surgical scars in her preauricular areas, so from removing the pits and whatnot. Narrow canals were also noted. The PE tubes were intact and they weren't clogged. Then she also had a facial exam where the epicanthal folds were noticed and a flat nasal bridge. But now at this time, they noted the presence of a branchial cyst mass right on her sternocleidomastoid muscle. So here is the picture of little girl Doe. You can see that there are 3 figures here, and there are arrows in each figure. Those arrows are depicting the existing or surgical excised branchial abnormalities. So you have the arrows with the pits. Then in the middle, you have where the cyst or where the scar is from the sinus. They don't really show you where the mass is. And then in the far picture, where there are the 2 arrows on the little girl, you can kind of see that the top of her ear, it's harder to see, but it is rotated forward, and it has a little bit more of the cup visualization. You can also see that in the middle picture. When you look at her face on, you can see the difference between the two ears there. So now we have some more good stuff. We have a picture of an ultrasound. So you can see they did a intravenous pyelography, and that basically showed that the left kidney agenesis, remember, is a missing kidney, one or more. So the left kidney was missing, and then she had a hypoplastic right kidney. Then they did a renal ultrasonography, which showed bowel loops in the left renal fossa. So I'll give you some definitions here. Bowel loops happen when the small intestine forms a loop that food bypasses during digestion. So that loop that's formed basically obstructs the digestive tract and makes it difficult to digest food. It's not very comfortable. Not that I would know, but I would assume that it's not very comfortable. And then the renal fossa is an area where the kidney is not located in its normal location. So the kidney is supposed to be within the anatomy, the region called the renal fossa. So in this case, the bowel loops are in the left, where the absence of that left kidney, that's where they see these bowel loops. I have a hard time kind of figuring out this diagram. So if anybody has a good way of explaining it or understanding, definitely welcome the question and or comments after the presentation. So now this is obviously more up our alley, speak in our language. So they did pure tones and they did speech testing. So pure tones, they reported it to be mild to moderate conductive hearing loss bilaterally. I would, say that it's a little bit, it's a little all over the place, but I would go with it's, moderately severe and then kind of essentially in the right ear with a couple frequencies in the mild range. And then the left ear, I would say, is about moderate, more essentially moderate with a frequency in the mild range. So you can see there's a pretty hefty low frequency hearing loss. Well, there is hearing loss across the board, but it's just an interesting configuration. And when they did speech testing, her SRTs for the right ear were 30 dB and the left ear was 35 dB, which they didn't go into saying whether or not they masked or how loud the presentation level is. So, like I said, you kind of have to take these results a little bit with a grain of salt. And then discrimination for the right ear. Again, they did not explain whether, what the presentation level was and or masking. But patient obtained an 88% in both ears. So more significant history that we're going over. They followed up with her 9 years later, or when she was 9 years old, and she was prescribed with hearing aids, and she continued using her hearing aids. They reported she was doing really well with them, and at that time she also had bilateral TM perforations. And the authors reported that she also had temporal bone imaging to see what, possible structures, how the fusion of those ossicles were, and the absent process of the incus, just to have for their records. Since she was referred to another location, they needed to have more information. But the temporal bone imaging was not presented in the study, and it just mentioned that that was completed after the TM perfs were reported. So I don't know if you remember, but I said she was a proband, which means that she's the first in her family with the genetic disorder to be studied. So the other cases in this case study were interesting because they were the little girl's brother, who was 4 years old at the time that she was being studied, and it was her mother, who also was studied. So that was interesting. I don't go much into that, but it's just important to note that anytime you see a person with BOR syndrome to kind of understand that the reason they have this is due to the inheritance pattern. So that's something also to keep in mind. If there are any questions, feel free, to post on the discussion board, and I will do my best to answer them. I hope this gave you all a little bit better understanding of what BOR syndrome is, specifically the presentation of hearing loss. And, feel free to read those articles. They talk a lot more about the hearing loss, but again, there is some contradictions with the level of severity and the pattern, whether it's fluctuating, progressive, or stable. So just all things to keep in mind. If you see a person in your clinic with BOR, you might have a better understanding of all what's going on. So I'd like to thank everybody for watching, and have a good evening, day, whatever it may be when you're watching this. Thanks, guys.